Hello, everyone, and good evening. My name is Michelle Laporte, and I am the Marketing and Education Manager here at Biotech Dental USA. Tonight, we are honored to be joined by Dr. Robert Reti, who is going to be presenting his When Implants Don't Go as Planned, Prevention and Management of Implant Complications presentation. Dr. Robert Reti is a board-certified oral and maxillofacial surgeon who completed his surgical training at Tufts Medical Center in Boston, followed by an advanced fellowship at Mercy Hospital in St. Louis. With extensive experience in dental implantology, bone grafting, facial trauma, TMJ disorders, and reconstructive surgery, Dr. Reti is passionate about helping clinicians achieve more predictable implant outcomes through practical, evidence-based education. So without further ado, Dr. Reti, you can go ahead and unmute yourself, turn your camera on, and you can begin sharing your presentation.
All right, thank you for that.
Absolutely.
All right, good evening, guys. How are you? Thank you for joining me tonight. I know you have much better things to do, and again, trust me, I have two young kids and also a gorgeous wife who can do way better than me. So I'm always on my toes here, but I do appreciate you giving me some of your valuable time to hear me ramble. Before we begin, I have to give a shout out to Biotech for allowing me the opportunity to speak to you. A big thanks to Randy Miller, my local rep here in St. Louis, who is the most responsive rep I've ever worked with. And those who have had the opportunity to have met her, you know exactly what I'm talking about. Michelle, thanks for giving me the opportunity to speak, as well as Scott for tolerating my ADHD. And finally, Davidson, the big boss that that thinks I'm not just a big goofy oral surgeon, and I cannot wait to try all the cool things down in the pipeline that I cannot talk about yet. And I hope you find this lecture valuable, and hope the opportunity to speak to you again at a live course or virtually again. For those who don't know me and why you should even listen, well, I think I provide a good balance between academics and private practice. I'm sure you've heard the saying, those who can't do teach. Well, I teach and I do. My main
Hey, Dr.
focus is full
Reti,
scope. Yep.
I don't think your screen is sharing just yet, if
Oh,
you're
I
wanting to.
apologize.
I could see the glare in your glasses, and I'm like, I think he's
Let's-
wanting to share.
All right, where is the screen share button? There we go. There we go. Okay. That better?
Perfect. There you go.
There
Yep,
you go.
continue.
Sorry, guys. I'm not the best at technology. Well, again, so I think I provide a good balance between academics and private practice. You know, I teach as well as I run. You know, my main focus is a full scope private practice here in St. Louis, where I do a lot of dental implants, a lot of All-on-X. Did one this morning as well. I've seen it all and I failed at all, and this has humbled me. I also work and teach at the dental school at ATSU. I teach at OMFS Fellows at Mercy Hospital. I also teach the WashU plastics and ENT residents as I am part of the Department of Plastic Surgery. What makes me unique is that these are my patients. A lot of these patients have choices where to go for care, and I need to make sure I don't stir the pot and upset any of my referring doctors. Let's be honest, in academics, there's a sort of a level of protection and expectation. I'm not studying these patients, I'm treating them. So when I give my opinions, you know, they're not always based on published literature, but on how I feel I can provide the best and most reliable outcomes to these patients as a whole. I have limited time tonight, so obviously I can go over everything. I'll go over more real world complications. I've been told I have about 45 minutes to 1 hour. I don't have a 600-page textbook, so there's lots of good resources out there that you can check on in. So I'll try and kind of limit to what I actually covered tonight. And don't worry, I have left one cool, gory oral surgery complication for last. For I got to show off a little bit, as well as a little bonus for those who actually stayed to the end of the actual lecture. But most importantly tonight, I'm going to give you my experience on how, as a private practitioner, I handle these situations. I'm sure there's some big name docs out there who are going to disagree on how I approach things, but I promise you, I approach things with a rationale, and everything I do and teach does not break standard of care at all. I don't have 50 appointments and unlimited follow-ups to treat all of these patients, so let's go into the actual lecture itself. Cover through exposure. Happens to all of us. You place an implant, you come back in the next amount of months, and you can see the cover screw is peeking back at you. It could be for a variable number of reasons. You know, you could have had some bacteria at the time of the implant placement, place your sutures too tight. they're wearing some sort of prosthetic that's on top of the tissue riding it. You could have closed the flap under tension more commonly when there's not enough keratized tissue over the actual site. You may have handled the actual flap poorly, and it's kind of mangled on up and also lacerated. You could have muscle pull, especially if you have a really, very small mandible, like K Wood 5. You may have muscle pull along the edges, smokers, or you may have placed the implant supracrestal, or more common, this might happen, an implant that's placed at the same time as the extraction. A problem is we don't often know it even happened because these patients are not going to say, "Hey, I'm having a lot of pain, a lot of discomfort." And the key is early diagnosis. And really, we should be checking these patients regularly between the implant placement and the time of the osteo integration check. But patients don't want to come in 4 or 5 times for the same thing to be let go and say, "Yeah, you are fine." Also, obviously, it's inconvenient to the actual patient as well as it'll take up a lot of your own chair time. Dr. Tal has described a classification system on cover screw exposure many years ago. If you can't tell by the quality of the graphics from his article, type 2 and 3 being the most common with partial exposure, type 0 meaning the cover screws are totally covered, no issues at all, and type 4 with when the entire cover screw is exposed. The problem is titanium does not integrate into the soft tissue. This leaves a flap for bacteria to hide, kind of similar to a pericornitis on a wisdom tooth, and you're certainly going to have some bone loss on your final check on your periapical films, especially if this goes unchecked. As I mentioned, you'll see some bone loss with higher levels of classes developing more bone loss, of course. This of course puts your implant at risk for aesthetic issues, discomfort on chewing once you load it, and of course, it also puts your implant at risk for the dreaded peri-implantitis. I don't have a lot of time to go into great deal on this one, but this is one of the reasons why I do advocate for replacing biotech implants and why they like to place their implants subcrestal. Placement of their implants subcrestally should help prevent this because like crowns, your crown on an implant also needs to have a biological width. So there's been some great studies. I know those who follow Dr. Linkovis. I can't really pronounce his name. I'm sorry for butchering it. And Dr. Goldenberg has told me at least 30 times how to pronounce it. I just can't. But the literature shows that if you have at least 2 millimeters of thickness of tissue above the implant, you can place your implant crestally. But to try and account for the biological width, if you have less than that, if you actually can place your implant subcrestally, if the implant has a Morse taper as well as platform switching, you can place your implant subcrestally and have no bone loss. Anyways, let's go on to what I actually want to talk about. The overall idea is when you have a cover screw exposed is to keep it clean to get rid of the bacteria. There's only so much you and your patients can do. They cannot really be on antibiotics for the entire healing time because that's going to lead to a gut issue. And yes, they can only clean at home so well with a toothbrush. They really need to have some debridements. Dr. Barboza has offered a few modalities to treat this. The first one, obviously, is to come in every few weeks, debride it, clean the site, as well as instruct the patient to keep the air clean at home and take serial radiographs to evaluate for bone loss. But these are real people who have other things to do but hang out at your office every few weeks, especially if you always run on time, just like me. So to me, that's a little bit ridiculous. Plus, you're having a lot of radiation exposure. Modality number two is basically antibiotic therapy, especially if there is purulence. You basically place the patient on systemic as well as topical antibiotics applied to the area, as well as take a sample or a speciation. The problem is with taking some kind of microbiology, one, it'll take about a week to get back. Two, we actually know what kind of common bacteria are actually growing, and how also there's a question of how practical this is or even necessary. Of all these bacteria are symbiotic, they work together. If you just kind of knock off a few of them, and then the antibiotics will do their course. Um, that being said, you're still going to have some bone loss because you do have an infection. Modality number three is actually just placing the healing abutment. It allows for the cleanliness of the flap, and it's simple, it's easy, and straightforward for you and your patient. Now, you're probably thinking, well, I put it on the cover screw for a reason. Either you can achieve torque of greater than 35 newtons, which I advocate in my courses, or you always do a two-stage procedure, which is absolutely fine. That's how I was doing it when I first started placing implants as well. So the question is, can you place the healing abutment? Well, a lot of the other systems as well will say that you need to at least have at least 20 newtons of torque to place on the healing abutment. To be honest, as long as your implant's not a spinner, then I would advocate putting on the healing abutment, and as well as asking the patient to be on a softer diet and avoid eating on that area. Again, you might have some bone loss regardless, but the whole idea is trying to mitigate that as best as you can. Now, fracture implants, nightmare scenario. Your implant has fractured. Congratulations. Somehow you broke a titanium screw. It is officially dead, which is impressive when you consider the average human bite is only 1 megapascal, and a grade 4 titanium implant can handle, pressure up to 550 to 680 megapascal. So it's a lot of force. Yeah, the problem is your patient feels this infallible treatment that you've kind of harped to them and promised them, has very few, low failure rates and is now broken. And the problem is now all those internet stories that they heard about are true. You're now pointing your finger at the implant rep. They're pointing their finger at the lab. The lab's pointing the finger at both of you. But regardless, this patient has invested $3,000 plus for this implant, and now it's all down the tubes. And your goal is to get this patient back to some kind of normalcy. Now, what are the risk factors for implant fractures? Well, of course, a non-passive fit of your prosthetic. If you have a very short implant, inside a very short small amount of the implant in the bone from peri-implantitis, biomechanical overload. They may be bruxers, clenchers. You may have a very large cantilever. Some of the older tri-channel designs where they had a triangular insert where those thin wall meets. I had a lot of fractures many years ago. It goes on that where the implant would actually flower. Of course, in high pressure regions like the molar or the premolar region, narrow diameters, and especially in a place where a larger diameter implant would have functioned better. And of course, screw retained implants because it just places a little more pressure on the implant directly. The question is, do you need to take out this implant? And if you have to, how do you do it? Well, you have to understand that this is titanium. Do you really need to move this implant at all? The body does not know it is even there. It is biocompatible. If the implant's not totally fractured, maybe a hairline fracture, can you put on the cover screw and just sleep it, or grind down a little bit so it's underneath the actual bone line? Do you need to actually put the implant back in the exact same spot where the implant has actually fractured? Can you work around it? How much of the implant is still left? Is it a fracture in the apical or the coronal area? Again, those are all things we need to understand because removing this implant is like removing an ankylosed root. It's basically stuck in there. So the first thing you can always try and do, if you can still get your driver into the implant channel, is to try and do a reverse torque. A lot of times this can work out for you. So I always advocate that is your first course of action. If not, there's a really wonderful tool called a Trefine that makes the job really, really simple. A Trefine comes in different diameters. Of course, you choose the diameter based on the implant that you're trying to take out. And they actually have marking depths to tell you how deep you are inside the actual bone. Of course, you need to take a cone beam, find out how deep this fragment is. And for your safety, you can even try and drill just short of the total length of the implant that you're taking out to make sure that you don't drill into any kind of vital anatomy. And that last millimeter can be easily luxated out and the whole implant can come out. If you plan on replacing the implant at that site, I would graft it like a socket preservation, return the mount at right time based on the graft that you have chosen, and voila, you can come back and replace the implant for that patient. There we go. But you see just how thin layer of bones comes around it. You just got to choose the right diameter of a Trefine based on the implant that you're taking out. Eye and nerve. This is a scary one. Most implant complications are reversible and can easily be corrected. Yes, maybe a bit more time, a little bit more effort, but very rarely is there a permanent issue and litigation risk. The eye and nerve is something I taunt every day, but I have the utmost respect for. The eye and nerve, like most anatomy, is variable in its course. If you're doing implants, you need to make sure you have a cone beam when you're planning these implants. The eye and nerve enters from the lingula and goes from the lingual to the buccal cortex and exits through the mental foramen. It is sensory to the teeth and the anterior mucosa of, and also the lower lip of the midline on that side. Patients, if you damage this nerve, will complain of the inability to drink without spilling on themselves, unable to be intimate with their partners, and speech problems. Yes, I have been an expert witness when the patient and their partner were involved in the litigation. So for those who place implants, I'm sure sometimes you have difficulty finding the canal, especially in soft bone. So it's not always easy to identify, but you have to keep in mind that it's classically recommended to be 2 millimeters away from the IN canal, as we not only worry about not only direct injury, but thermal and pressure injuries as well. Because again, there's not always going to be a nice thick cortice around the IN canal. Now, my best advice is going to be avoidance. You do not need the longest implant that can fit in that site for, especially if you're not doing an immediate load. After integration, the majority of the forces of an implant is at the first 5 millimeters. Be safe, go short. You aren't any cooler or hip by using a longer implant. We don't expect the bone to lose. We don't expect the bone to be losing bone, the implant to be losing bone over time. So you don't need a longer implant to kind of buy more time if you do have peri-implantitis, especially if you're planning these implants properly. Nerve injury in a nutshell, there's 3 injuries. Neuropraxia basically means that you kind of bruise the actual nerve. There's no actual transection or direct injury to it. You expect them to have full recovery. Exonemesis, there's damage to a partial portion of the nerve due to crush, compression, or swelling, or the implant actually touching a part of that actual nerve itself. It'll heal likely in weeks. They're probably going to have some sort of deficit. And there's neurotomesis, which is a transection of the nerve itself. They're going to have anesthesia, no feeling whatsoever. In fact, they may even have dysesthesia, which is painful nerve feelings as well. Unfortunately, there's no good imaging that you can take, not even MRI. Yes, you'll take a cone to make sure, like to look at the actual canal, to make sure it has not been violated, but there's no way for us to kind of follow these with imaging. What do you do? Well, if you catch on post-op, which you should, because you're taking your post-op X-rays. Well, if you have some IV Decadron or dexamethasone, you want to pour it inside the canal itself. Also, give it to the patient IV. Give them a Medrol dose pack at home. Hopefully, reducing the swelling will help let that nerve kind of regenerate better. You do not bone graft or put anything in that canal space as well. You want to leave the two ends of that nerve capable to find both ends of one another, so it'll heal better. Vitamin B12 has been shown to help in nerve regeneration. Omega-3 fatty acids, I usually give a high dose amount, 3 grams daily for 1 week, then 2 grams for 1 week, then 1 gram for 1 week. Kind of like it's been shown to help in traumatic brain injuries, but we also give our kids omega-3 fatty acids because it helps nourish nerve cells. And of course, you have to know how to sensory map, and you want to do this weekly, where you're testing the nerve and seeing how it is progressing. If you aren't comfortable with this, you got to send it to a specialist and early. The earlier the intervention, the better the outcome. So if you do see that the nerve has been transected, you got to send it off to someone who can do nerve repair immediately. If it's not witnessed, where you don't actually have the nerve or the canal that was violated, IN nerve injury should be treated hopefully in the first 3 months to have the best gain in sensation. You have to understand, when you do a nerve repair, you're not going to get a perfect nerve again. They're going to have a deficit regardless. Even if they can feel, their lip or their finger touching their lip, that is considered a successful treatment. We don't use a sural nerve anymore. We use basic cadaveric nerves when we fix these, but we'll go in, give it a look, and see if there's kind of scar tissue or any kind of neuroma has to be taken out. All right, fibrous union happens to all of us. Do not feel alone. All right. The good news is normally patients are not upset at you. They don't feel any symptoms. There's no pain. They're chewing well. They're chewing on the implant. There's no bleeding. So they're just as dumbfounded as you are, like, what happened, which is good news in a way. Radiographically, when you take an X-ray, you'll see kind of this thin layer of radio opacity where the implant's not touching the bone. So when the integration process fail, it often is due to excessive movement, bacterial infiltration, or some autoimmune system reaction. The body halts bone formation and basically tries to isolate the implant by creating an immune and fibroblastic deposit of thick collagen-rich scar tissue around the actual implant itself. It can be caused by a lot of issues: bacterial infiltration, the micromovement, overheating, over torquing, or just the patient's poor bone or poor bone quality, or just has a poor healing capability. A lot of things that can, that we can do to reduce this. The number one thing is overheating. The critical threshold for thermal bone injury is 47 degrees Celsius for about 1 minute before bone dies off and is replaced with fibrous tissue. I see a lot of docs just kind of press down on their drills, like straight on down. When you're actually drilling these implants, make sure you're pumping your hand up and down to allow the irrigant to get to the apice of your osteotomy. You can use cooled irrigation. That should put your irrigant in the actual fridge. Make sure you use sharp drills. Manufacturers recommend replacement of your drills every 20 uses. If you have a dull drill, you'll have a dull osteotomy, and that's going to overheat quickly. And when you're pushing on these drills, make sure that the drill is doing the actual cutting and not you putting a lot of pressure on the drill itself. Make sure there's no pressure on your healing abutment. If you're using any kind of temporary anesthetics or a partial denture, make sure you account for the height of the healing abutment and make sure that there's no micro movement. If you are doing temporary crowns, immediate temporary crowns, not only do you have to make sure that the tooth is out of occlusion, but make sure the mesial distal contacts as well aren't touching, because when you start chewing on those teeth, if those teeth adjacent start moving, it'll put micromotion on your implant as well and could cause it to fail also. Pressure necrosis, bone damage caused by excessive pressure or force from or to the surrounding bone. I know there's some people online who think it is all fake. I try and keep my implants less than 70 newtons centimeter. Um, Issue is that the cortical layer of bone lacks vascularity, while the trabecular layer has good vascularity and can be compressed. Cortical bone does not like a lot of pressure on it, and it likes to remodel quickly. So if you're going to, if you find that your implants are super tight, you can go to you can just prep the top of the cortical layer with the next size up, or you can use the drill which has the same diameter of your implant. But you want to make sure that you're not putting too much pressure on that cortical bone. The treatment, of course, is very simple. You unscrew it, and you can either, if you want to go in to bride that fibrous layer, you want to put a graft, let it heal, or if it's appropriate, you just put a wider diameter implant if it's appropriate. You have the same time to heal. Usually, for some reason, you put in the second implant and things just work out. Now, peri-implantitis, this was a hard one. I hope to make it as simple to understand as possible, at least on how I interpret it. Peri-implantitis is seen as the equivalent of periodontitis around natural teeth, and this similarly occurs when the overwhelming bacterial insult leads to a destructive host immune response. Implants are at a disadvantage compared to the implants are a disadvantage compared to teeth from the oral cavity environment, because the connective tissue is oriented in a parallel fashion versus a perpendicular fashion, so bacteria can easily enter the sites. Making this all worse, of course, is that all those cool features which your implant has integrated to help. Sorry, your implant is added to make sure it integrates well by creating a lot of rough surfaces. Also loves to harbor bacteria. But like everything, there are levels to it. And like teeth, once the bone is minimal around the implant can fracture or even fall out. So depending on what stage you're at, you have different options. But again, this is a continuum. Once afflicted, the implant is in a guarded and is forever in a disease state, just like periodontitis. So you have ailing, which will have some erythema. The threads aren't showing. It has some deeper probing, some bleeding points. failing. Now you're actually feeling the threads of the implant with your probe. And of course, it has a worse prognosis. The more bone you lose, or the more exposure you have with the threads, the more chances it's going to fail. And of course, you have failed, which is implants are now mobile or even fractured. So you have some non-surgical options, usually better if it's a mucositis. You can, mechanically debride the actual abutment, apply some topical steroids, usually taking off the prosthetic to allow you more access can help. You can get a lot of these topical antibiotics through your pharmacy in a powder form and make it into a slurry. Yes, you definitely should be using plastic or carbon fiber tools, not to scratch the implant, causing more surface roughness for bacteria to breed. The biggest issue is how long can you really do this for, and how long until you get antimicrobial resistance. Some drugs have been tested, as metronidazole as well as minocycline. You can get a gel of both actually, metronidazole and also of minocycline. You can even get a lot of these antibiotics you can get from the pharmacy in a powder form and just make a little slurry out of it. Surgical options, well, um, obviously, the less thread exposed, the better outcome, but you can do some access surgery where you actually will open up the flap. You'll debride all of the implant with scalers, titanium brushes, air powder abrasives. The issue is that once you open the flap, there's a high chance that you actually might have the tissue recede and actually show more threads. You can do a reconstructive, is best, and this is best if there's only four, if there's three, or there's a four-wall defect. Because you need something to help contain the actual graft itself, but you'll go in to debride the actual implant and put some kind of grafting, either soft tissue or a bone graft, or last resort, better, if there's already threads showing, where essentially you do a resective surgery where you will actually try and smoothen the implant surface, or in implantoplasty, and trying to remove some of the biofilm and make the surface a little smoother. Of course, there's a risk that by smoothing the implant, you have a higher risk for the implant to fracture because you make the implant even more narrow. My take as a private practitioner, all these treatments are not predictable. You're really just buying time, and this may work for some, but it's always going to be a guarded prognosis. And again, literature is always changing on this, and there's always different approaches, being studied. I always do the mom test. You got to take their age into account, their health into account, and their desires. Obviously, time is bone. And that bone is the same bone that you can put the implant in. The question, of course, is, do you want to do multiple treatments and frustrate this patient and lose their confidence? It's usually not a single treatment, but there's a cycle of surveillance, then treatment. If the implant's early on and not restored, I always kind of move toward just taking it out. If it is restored, that's when I start saying, all right, well, I can try and do this for you. Here's honest truth. It's kind of a coin toss. My preference always, I tell the patient, is to be remove the implant, graft it, and replace it. And this will cause less discomfort, less stress, less cost to the patient, time, and also pain, and it's the most predictable. And if you do peri-implantitis, I know I don't follow the literature, but again, the literature changes every month. There's always someone coming up with a new idea, so there really is no standard approach to this. The goal is to remove the biofilm, period. I like using acid etch because it's highly effective for removing both mineral scale as well as tough extracellular protein matrix of a biofilm. And remember, the key to success is a two-step cleaning process, because acid alone will leave some living bacteria behind that can grow quickly. So again, I personally use etch, believe it or not, but you can use 3% hydrogen peroxide. You can use tetracycline, but the idea is we want to break down that biofilm. So my regimen personally is, if I'm doing an open debridement, is obviously I'll debride with my titanium brushes. I'll irrigate with chlorhexidine. I'll then add acid etch for about 2 minutes, wash it off, debride with my wire brushes. I'll acid etch again, irrigate with saline. Again, I'll debride with my brushes, irrigate with holy water, chlorhexidine. Why? I don't know. It just makes me happy. And I'll go back and I'll graft with some sort of graft with PGRF, a bone in there. And again, I put a little membrane and I sock it down. Here's an example of a patient which I didn't place the actual implant, but it was one of my employees. I was very upfront with them saying, yeah, you have some bone loss, but the area looks contained. I can try it. 4 years out, and it still looks really great. You spend a little tack there. So again, with peri-implantitis, everyone has their own flavor. This is mine, but my preference is always to say, hey, you know what? Time is bone. If we take it out, you'll actually have the best outcome. Surgical site infections. Obviously, we use our clinical judgment of who should get antibiotics. It's a very low reported rate, about 2 to 4%. We still don't know really if the antibiotics are beneficial or not. We have to keep in mind that giving antibiotics to 25 people will avoid one person experiencing an early loss due to infection. It's still unclear whether postoperative antibiotics are even beneficial. But that being said, we know that giving patients antibiotics in general, about 6 to 7% of those patients will develop some sort of adverse reaction, and a small percent of them will actually develop anaphylaxis and even possible death. So we got to weigh the pros versus the cons. Again, over the years, this question has not been totally solved. Even when I was a resident, these were the papers that we're all reading, and all of them say you use an antibiotic before, after, between, throughout, has the same results. There's no significant difference. So that, and to me, again, this is amazing. If you actually look at the orthopedic literature, our colleagues are putting in titanium hips in patients. They have to wear hazmat suits to do this while we're going through someone's lunchtime hour, full of like gunk, and things still work out really, really well with a very small failure rate. So it's really our clinical intellect and intuition if they need antibiotics. Of course, if the medical history paints a picture of a sick person or at risk for infection, let your clinical judgment make the choice for you. I have learned that if you don't give them an antibiotic, their primary care will. And if something goes wrong, they'll blame you anyways for not giving you an antibiotic. It's kind of one of those moral, topics as well. That being said, if you are going to prescribe an antibiotic, it's best before the incision, and it's best to provide a penicillin-based antibiotic. If they're allergic, ideally get them tested for penicillin allergy. You'll be amazed that 90% of those who claim to be pen allergic actually aren't. And penicillin is great for so many other ailments. So them finding out it truly can be beneficial long term. If they claim to be penicillin, if they claim to be penicillin allergic, and they don't report a really life-threatening reaction, you can try second-generation cephalosporin. That may be the next best thing. Surgical site infections. What do you do if you actually have one? Well, it depends if they're superficial or they're actually creating purulence. If they're superficial with a perilous, you may want to try doing some oral antibiotics first. Again, amoxicillin by far is the best medication for this. Alternatives, if they really have allergies or you don't want to give them amoxicillin, could be doxycycline, moxifloxacin, or azithromycin. Normally, it takes about 48 hours for antibiotics to reach a good level where they're actually active. So only about 4 doses. So consider doing a loading dose. If you are going to do a loading dose of doxycycline, it's a 200 milligrams. A Z-Pack, the actual pack gives you a loading dose of 500 milligrams the first dose. Amoxicillin is obviously 2 grams, and then closely follow up with these patients. If there's no improvement or that you have a purulent or facial swelling or actual trismus, you got to remove the implant. The bacteria is going to seed on this implant, lead to a biofilm. You will get bone loss and then eventual peri-implantitis. Usually, it's the best time to remove them. They'll unscrew. There's no biological integration. This time that you want them out. You actually may need some incision and drainage. If it goes beyond the alveolus, I would recommend about 4 to 6 months of healing. And after removal of the implant and then antibiotic therapy, do not place any bone graft at this site. That bone graft will act as basically food for the bacteria. So it's something you don't want to do, but give time for the tissue and the bone to heal and the bacteria to be expelled. Sinus displacement normally causes there's inadequate bone below the sinus floor. It's common when you're planning these implants on an orthopanogram, aka Panorex. It may be caused by weak bone or there's a sinus infection that causes the bone to be weak, or of course not changing your implant speed, causing a rapid placement too far, and the implant goes into the sinus, oopsie, or excessive pressure on the implant during placement. Remember, the bone, especially in the posterior maxilla, is more D3, D4 bone, much more softer, can be easily be compressed. Now, the rule of thumb is to keep your implant, see about 2 millimeters below the sinus floor. If it's less than that, a sinus lift is suggested to prevent sinusitis or sinus puncture, or of course using a shorter implant. The good news is the sinus is a very forgiving environment. I place implants near the sinus floor all the time, especially for fixed prosthetic. We place trans-sinus implants, actually going through the sinus, and Zygomatic implants were taught to be placed intrasinusally the entire way up to the root of the zygoma, about 34 millimeters inside, and things went pretty well. The review of the literature shows that even if you're in the sinus a little bit, less than 4 millimeters, usually you'll have the same outcome as a implant placed subsinus. So the sinus is really, really forgiving, believe it or not. Now, if this does happen, and it has happened, it's not a medical emergency. Do not scare the patient. This will not cause immediate harm. There's no need for, of course, to wait for fibrosis, because the implant's just going to roll around in there. It's a big air pocket. You do need to remove the implant. It'll act as a foreign body reaction if kept in there, but it's not something that's to be done at that moment. So don't scare them. I would place the implants. I would place the patient on some antibiotics to cover the sinus floor, Augmentin or a Z-Pak. You can attempt to remove the implant through the hole which the implant came out of. Just enlarge the osteotomy, and you can try and put your suction in there, shove some packing covered in Vaseline or Xeroform gauze, see if that'll kind of grab onto the implant and then bring it through. But most commonly, we do a culpable luck approach, where essentially we'll come through the canine fossa, and it will allow us entry into the sinus itself. Now, this can be a little tricky because remember, these implants are just hiding in bone. So when you take your x-ray and the patient's all straight, obviously the implant's laying on the floor, and when they put their head up for you to get access to the sinus, it starts rolling around. So it may take a little time to kind of get these out, but usually they come out in a few moments. It's not very traumatic at all. And again, nothing that will leave some serious harm. That being said, if they do want an implant down the road, it can be a little tricky. One, because you actually have to cover the tissue up because you will have an oral enteral communication. So you have to do some kind of buccal fat or some buccal flap advancements to actually cover the hole. But the actual sinus mucosa, which you covered up with, will fuse to the flap that you're actually creating. So if you do plan on doing an implant down the road, you'll have to do what's called an extended sinus lift. You actually have to remove the actual osteotomy bone surrounding part of your actual sinus, your sinus lift. But this may be a better case. We're offering another solution like a fixed partial denture. It might be the more easier way to kind of get around this. Implants too close. Well, the general rule is 1.5 you need about 1.5 millimeters between natural teeth and 3 millimeters between implants to retain bone vitality. The problem is that blanket statement is not true for everything. You always got to plan from the crown down, and just because there's bone there does not mean that patient is a great candidate for an implant. If they've lost a crowding, an orthodontist consult should be first. Implants don't move. Therefore, this may be the right time to motivate them to get on the aligner case. Of course, if you're not sure about the spacing, get a guide. It's a pet peeve of mine, but if you're restoring that implant, you want the best possible placement. These guys are quick to make. You can bill for them, and it gives you insight not only about if there's enough room, but the spacing, as well as the bone quality, and if there are any things that might happen during surgery which could make it difficult. If you do have implants that are too close, this becomes a hygiene nightmare. You're going to get bone loss, and you're going to get peri-implantitis. I'm a huge fan of measuring 3 times, cutting once. The standard of care does not change if you're a periodontist, oral surgeon, or a GP placing implants. So the fix, unfortunately, is going to be prosthetically having these really long contacts. But again, it looks not the best, and of course is a huge issue when it comes to actual maintenance and hygiene of these implants. Implant injury of adjacent teeth. Again, worst, nightmare scenario. It does happen, of course, hopefully not intentionally. But the problem is, one, is that when you have an implant that's touching your tooth, you can damage the tooth, but also imagine the emergence profile of that crown. It's going to lead to a hygiene nightmare for these patients. It's too close to the next tooth. Also be hard to restore, extreme angles, limited space. Things that you can do is, one, when you do your pilot hole, take an X-ray with the pilot hole in the osteotomy and see your angle. You can use it on every drill if you really wanted to, or again, believe it or not, just get a guide. It'll get you where you have to be, and also let you know if there's enough space. Also, this can happen if roots have great curvatures. Again, taking a cone beam and a guide and planning this will let you know if your implant will be close to that adjacent tooth or not. The good news is that, if you do hit another tooth, usually happens in the canines or the mandibular second premolars, that most of the teeth will do okay. Some of them will need to have root canals done. They'll need to be extracted. Of course, you tell your patient that on the post-op X-ray that you did hit the adjacent tooth. The implants survive. They do amazing. So 97% of them will survive and become functional still. So again, you can I would tell the patient you hit this tooth. Of course, if it happened on your post-op X-ray, I don't know why you wouldn't move the implant into a better position, but you do have to have a guarded prognosis of the tooth that is natural that is hit, and you have to follow up long term with them and make sure that you document it. Okay, especially in the first 3 months. Now, I'm going to leave you some of the bloody stuff that you all been looking for. So as an oral surgeon, obviously I throw in some good cases, but this case I really think summarized what is very important when it comes to implant complications. This complication was from a well-known, well-experienced surgeon in my town. Patient had multiple implants placed by the surgeon. They know exactly what they're doing. No issues on the upper jaw as well. He had a wonderful sinus lift grafting. They know what they are doing. Um, but when it came to the lower jaw, they had some issues. The patient was placed on multiple rounds of antibiotics for months without success. And finally, after the implants started coming out, fortunately, this patient's nephew was dentist in town and asked me to give it a look. Something just wasn't right. The patient was numb, in pain, and the x-rays would look horrible. So they came into my office, took a cone beam, and without any question, pathologically, I knew exactly what was going on. Osteomyelitis. This doctor either did not know how to recognize this or conveniently just ignored it. But we needed to act, and she was losing more and more of her jawbone. So we went in. We took some samples for microbiology. We took some samples as well as for pathology to verify the actual diagnosis. We got her set up with an infectious disease doctor to give her long-term IV antibiotics. We also set her up with a special scan called a tagged white cell scan, where essentially they drop your blood, they tag the white cells with a marker, they inject the blood back in you, and they take an X-ray to see where all those white cells ended up hanging out. I'll see how far this has spread to. Came back from the pathologist, obviously osteomyelitis. Because this doc was scared or unwilling or ignorant to what was going on or faced the complication head on, at this point, the complication had gone so bad, we had to remove a big portion of her jaw, basically from angle to angle. First, we took all of her teeth out on the lower jaw, allowed 2 months of healing so the mucosa wouldn't be communicating with the mandible below, and then went to the operating room, went in, took out a big chunk of her jaw. Of course, in the operating room, I got to play with everything. So I used BMP and advanced cellular bone grafting, which basically carries live cells as well as growth factors. Didn't have to go to the hip or anything. But the OR, I can play with almost anything I want, so it's kind of nice. That being said, great results. 8 months of healing, came back, guided, placed some implants for a fixed denture, okay? Fortunately, I got plenty of room to place the implants because the nerve as well was removed with this, because osteomyelitis not only affects the bone, but causes the nerve to be shot as well. In the end, great results, ended up with a great prosthetic, but the question is, did it have to be this way? So what can we learn? The simple way to avoid complications is to measure 3 times, cut once. Get a guide. It's made by a lab. It's easy to do. It tells you exactly what kind of bone you have. It tells you the best position for the implant. It helps you avoid some surgical issues, intra-op, which you may not have thought of. Plus, it reduces your inventory. If you know what kind of implant you're going to place, you don't even have a stock of 10,000 implants. But also learn when to say no and refer. If this is beyond your comfort, put it in someone's hands that can do it right for that patient. Always do the mom's test. Also, I can't harp on this anymore, the value of socket preservation. It works. It builds a solid foundation. It builds a solid foundation for the bone, but also the keratinized tissue. We offer lots of hands-on courses. One of them actually is socket preservation. It's so simple. It does not need to be 6 hours. My wife went to a socket preservation course last week, and it was 6 hours. I was just like, wow, like it does not need to be 6 hours. It's very simple. It's easy to add into your armamentarium, and it's very cost effective. Obviously, if you can't explain it simply, maybe you don't know it well enough. That being said, I hope you keep checking on the osteo session to see other courses that are offered by Biotech. Lots of courses are updated, and you'll see in their free CE, and it's taught by real doctors who love to actually teach this. And the catalog, keeps on growing for live courses as well as online courses. But I want to end by saying this. If you're serious about implantology, you need to accept not all cases are going to go the way that you want. You need to learn to accept, but more importantly, to get the patient whole. It's not about ego or super duper Harvard doctor, in dental school doing some crazy, surgery, costly procedure which is not good in your hands. You have to be able to understand what works in your hands and apply that. The literature is changing all the time. So again, keep up to date, keep on reading. There's going to be bumps in the road that may bring you down, and these are unfortunate situations, but it's these situations which makes you a better clinician. The key is to get a good group of doctors around you to support you and bounce off any ideas. If something goes wrong, I have a bunch of friends I can always talk to. We're actually in a group chat, and I learn the most from those poor outcomes. It happens to everybody. I don't care who you are, how seasoned you are. We all have bad days. And no joke, if you need to reach out to me, I'm always here to help you be part of your team and your development. There's my email, there's my Instagram. I'm a Southwest Oral Surgery, but keep on learning, enjoy the journey, and never stop asking questions. Good night, and we're ready to take any questions that you might have.
Thank you, Dr. Reti. There are a few questions in the
Please.
chat.
I love that.
All right, the first one is, what do you think about short implants in the molar area?
Love them. Literature has shown that they're equivalent to regular size implants. I regularly place 6 millimeter implants in the molar area, especially in those jaws that are atrophic. Yes, you have a longer crown, but the question is, how much pain and discomfort are you going to be giving the patient trying to do some vertical grafting? No, it's expensive, but it's not very predictable. It's a very certain skill set. So I love short implants. I think they work. I think literature over the past 15, 20 years have proven they're great implants. Only thing is, obviously, because they're shorter, I would plan more of them. I do, especially in the posterior, one implant per tooth. I wouldn't do bridges with them. I'd make sure that there are individual teeth on those short implants.
Perfect. Okay. Question number 2, for implants with persistent discomfort but no obvious radiographic findings, what is your diagnostic workflow?
My workflow, again, I'm all about simplicity. The reality is that sometimes there's fractures which you may not be able to see on X-ray, just like root fractures. You can't always see them. Obviously, if a J-shaped infection, around that. But my thing is, keep it simple. Implants, especially with the Trifine, are easily removed. If they're causing them pain, it's causing your patient to go crazy. What are you doing? Keep it simple. Remove the implant, graft the site. If the pain goes away, well, your implant was the actual problem. Sure, again, if you're probing and you find bleeding points, you find threads, yeah, then you have the option to treat it like a peri implantitis. But if there's some unknown cause, one could be neuropathic. And again, removing that implant is going to be the first step. If it's a big, again, if it's a part of a bigger prosthetic like an all-on X, well, then it gets a little more dicey. But again, can you replace that implant with somewhere an implant in the actual area itself? But again, I have a very simplistic approach to anything. Keep it simple. If it's bothering you, what are you doing? Take it out, come back and play again another day.
Perfect. And then question number 3, if a patient had broken an implant twice, would you recommend him going for a third time?
A third time. Well, the question is not very simple. The question is, was it planned correctly? As in, is it the right is it the right diameter? Do they have parafunctional habits? Are their bite is their bite adapted well? Is it equilibrated? Are using more implants? As in, have the load spread out? That's difficult to answer because, personally, if they broke it 3 times, does the patient even want to go through it again? That's the first question. Do they still have confidence? So personally, if the implant is fractured 3 times, I'd probably want to know what the cause is. Is it the prosthetic? Is it, the engagement? Is it the diameter of the implant? Is there parafunctional habits? Because implants don't fail easily. As I kind of showed in one of those first slides, the average bite is about 1 megapascal. These implants can handle a load up to like 900. So when you want to change to an implant with a grade 5 versus a grade 4, grade 4 is most common, but you may want to find an implant as a grade 5 implant, which has more strength. So again, I'm a big advocate of implants, especially if they're edentulous and they want to have the ability to chew and function normally. There has to be some reason why they're breaking that implant, and usually is the planning part that is the actual problem. Thank you, Dr. Goldenberg, for pointing out all of my errors. But yes, I would advocate trying again, but find what is the problem, etiology, how can you change it, how can you do better, and again, can you go to a grade 4 to a grade 5 titanium implant?
Great question and great answer. All right, last question. You had mentioned spinners. What is your approach to a spinner, and do you suggest removing it?
No, spinners are your best implants. By far, multiple studies, spinners, because there's no tension on the bone, heal the best. If you have a spinner, put it in, put it on your cover screw, give it the amount of time to heal. I promise you, not only is it in my hands, but every article I've ever read said low torque has the best outcome. Again, yes, it's kind of an ego kick because you always want the best torque, but sometimes you don't get it. That's fine, because really what keeps your implant in there is not the mechanical retention, but the osteointegration. So you'll get great osteointegration. No, keep them in.
Awesome. I love it. Thank you. Great answer. Well, thank you again, Dr. Reti, for all of the amazing insight. All of those clinical photos that you were able to show, I think is extremely helpful. For all of our attendees, thank you for joining us today. You should be receiving your CE credit within the next 7 business days. If you have any questions at all, you should have all received my email. You can email me directly with anything that you may need. And Dr. Reti is hosting with Dr. Pryor a live surgical course August 18th and 19th. So if you guys want to learn any more information, please visit our website, or again, you can email me directly and I can give you more information. Thank you so much, guys. Have a great evening.
See you. Good night.
Bye.